Good morning all, and this is with great pleasure that the Department of Oral and Maxillofacial Surgery, Faculty of Dentistry, Jamia Millia Islamia brings to you this webinar, Trends in Basic Oral Surgery. Times have changed significantly since any of us have been in a classroom recently, teaching or attending. With the ever-looming pandemic and the fast acceptance of online teaching, dental education has taken a new form. Webinars and online seminars have added great value to not only our curriculum, but also our understanding of the subject. As an initiative to keep updating our knowledge on the subject of oral surgery and continuously imparting wisdom gained from practical experience, the Department of Oral and Maxillofacial Surgery has started this webinar series. This is the first webinar in the series aimed at enriching our understanding of local anesthesia and basic management of maxillofacial trauma. And it is an honor to have the best of the best on this topic to talk to us today, Dr. Ramkrishna Shenoi. Before we start the webinar, we will have Quran recitation by Dr. Akil and Dr. Sadaf.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم.
I now call on our respected Dean Sir, Dr. Sanjay Singh, to introduce our speaker and to welcome us.
Very good morning, and I welcome you all on this webinar. And the topic of presentation of Dr. Shenoi, our guest speaker, will be on local anesthesia and maxillofacial trauma. Professor Dr. Ramkrishna Shenoi is a dedicated teacher, a researcher, an acclaimed academician, and a prolific surgeon. He is into this teaching for last 27-28 years. He did his BDS in 1990 and MDS in 1994, and presently working as Director Postgraduate Studies as well as Vice Dean, VSPM Dental College, Nagpur. Dr. Shenoi has lectured extensively. He's made more than 100 presentations in national and international forums, conferences. And ever since this pandemic has hit us, I think he has presented more than 50 webinars. And Dr. Shenoi is not only, he's done a degree in MBA also. He's an MBA. And he's been looking after the administration of his college. I think I remember since 2005-06, if it goes back to that time. And Dr. Shenoi, his dedication as a teacher, his students will vouch for it. I have heard from his students that Dr. Ramkrishna Shenoi is an excellent teacher. I heard him in conferences, and he really has a knack of it. With these few words, if I go on reading Dr. Shenoi's CV, it has a lot to do with IDA, it has a lot to do with AOMSI, he's held various post positions. He is always a proactive person who has worked for society, worked for students, worked for AOMSI, worked for IDA, and he is working for society. With these words, I welcome our dear friend, Professor Dr. Ramkrishna Shenoi.
Thank you for those lovely words, Dr. Sanjay. I cannot recollect any bigger platform than to speak at Jamia Millia. So thank you so much. I'll share my screen and we'll start rolling. So a very happy Doctor's Day to all of you, to your colleagues, right? And I think it was just by chance that the webinar came on the Doctor's Day, where we remember Dr. B.C. Roy. On a okay. So a big salute to Corona warriors, and I know, and Dr. Sanjay also would vouch that it's basically because of the healthcare workers and the frontline workers that we were able to bring down the second wave, which looked menacing in terms of the sheer numbers that people got infected. But then again, everyone pitched in, and then we could overcome it. So big salute to all of them. And of course, my tributes, my plural tributes those people who lost their lives, unfortunately, to the healthcare workers over this. So what I'm going to talk about today is predictable local anesthesia. Now, for the final years, you already had sessions on local anesthesia. For the third years who have joined and maybe, wanting to know more about local anesthesia, this is something which you are going to get practical tips. I'm not going to talk about dissociation, how the local anesthesia molecule is formed, made, benzene ring, so on and so forth. Whatever, we are not going to talk about that. You're going to get some practical tips because local anesthesia, if I'm not wrong, according to the syllabus, takes about 8 to 10 lectures minimum. So it's impossible to do justice to this particular talk in just 1 hour, right? The best thing about webinars is that, we get together, we exchange ideas, and then we come out much more enriched than what we were yesterday, from what we were till yesterday. Dr. Sanjay, you would not believe that I had spoken on this topic on the 19th of last month, 19th June. So it's just about 10 days. Yes, 10 days. I spoke at the Famdent platform. And since then, since this date got confirmed and all, so by that time, you tend to read more. In that particular webinar, there were so many things that were exchanged which you come to know. So the basic aim of such webinars is that, there's exchange of ideas, right? And there's a small disclaimer. I am not endorsing any particular brand over here. And another disclaimer is that, since from what I spoke in the last slide, I may not know everything. I would welcome to increase my knowledge in where I am lacking, and I'll go much more enriched than what I was. The volume on local anesthesia in dentistry is humongous, right? Malamed himself has written about 8 or 9 editions of his best-selling book. Plus, we read so many more books, textbooks. What I would recommend is that, for the students that who are there, who are more keen, because, dentistry is not possible without local anesthesia. I mean, even if you're doing, let's say, a smile designing, you need to do a crown lengthening procedure, you need to do a root canal, you need local anesthesia. Without local anesthesia, it's not possible. It's not, or local anesthesia is not only in the domain of maxillofacial surgery, it's there everywhere in dentistry. You need to make the patient comfortable, and that's why you need it. So the volume of literature is fantastic. What I would recommend is that, you could refer to this particular textbook by Malamed, and Malamed is a magician. I've had many chances of interaction as recent as 2014 at the FDI Delhi and again in FDI Bangkok. So I had a chance to meet him. And if you listen to his talks in those physical webinars, I remember the room was packed. It was jam-packed with people, a huge room was jam-packed with people. So that's the way it is. And the only job he has is to, he sits in his office and he's called in whichever department where the local anesthesia fails to act. That's his job. He does not do extractions of 1-1 or 1-8 or 2-4, whatever, right? The other one, this is a more recent one, which I found, which was very good. This is in the dental clinics of North America in 2011, and I'll be quoting it many times in my lecture. So this is Advances in Local Anesthesia and Dentistry. If you get a chance, I mean, I know you people are very tech savvy. You can download this from wherever it is, and I'm sure your library would be having it also. The main reason for which the patient comes in the dental clinic, even now, barring those places which are in the metro cities where the patient would come for smile designing, looking good, so on and so forth, is basically the patient has got pain and then you try to alleviate that pain. So diffusing the pain bomb is where we step in by giving local anesthesia. You do not have to totally knock down the patient and then do any procedure. The patient comes to your office, patient sits in the dental chair, you administer local anesthesia, stop the pain from happening, and the patient is comfortable. And that way, you get to get more patients. Because this is an interesting factoid that I got. When you do good practice, we are not allowed to, by oath, by our ethics, we are not allowed to advertise. If a clinic is there, a hospital is a different thing. We're not allowed to advertise. So the best publicity that we can get is, by doing good practice, painless practice. When the patient is referred by word of mouth, you get about 6 patients in that particular order. But if you do a bad job, if the patient is not comfortable, the patient would tell it to about 20 different people. So you need to be very cautious about this. These are certain things, which our curriculum doesn't tell us. Practice management is not there in our curriculum. I'm sure that people like Sanjay Singh, who are, authorities would make sure that we have a few little bits on practice management too. So anesthesia is important, but it's the impact on its practice is not perceived. So that's what I was talking about. How effectively we can quell the pain. The patients do not expect pain. So even if suppose you're doing a subgingival scaling, right? It is better to see that, or root planing, better to see that the patient is comfortable. And there are many agents which I'll be talking about later, right? I want my patients to be satisfied so that when they come back, I said just now, 6 patients, you do a bad job, your name goes to 20 people, right? Patients are afraid of the needle and to be in pain. So we have got newer advances. I have this in my hand, right? This is something called as Sure Shot, and we are doing a thesis on this particular thing. So this is a needleless injector, okay, and I'll be showing the video very soon. So obviously anesthesia is important and patient satisfaction is dentist's #1 priority. If you talk about the timeline of the local anesthesia, Kohler and Gartner were the first ones to use local anesthesia in 1884. Cocaine, if you remember, is the American Indians, the Central American Indians, they used to chew on it and they used to get circummoral numbness. So that's how they realized that cocaine is a potent anesthetic. Then Halsted injects the classical pterygomandibular nerve block or the inferior alveolar nerve block. Einhorn was one of those pioneers. He was a German chemist who synthesized cocaine. It's an ester. It was very popular, but then it came to fore that it's got a lot of side effects, basically hypersensitive reactions. And then finally, the workhorse of local anesthesia was by Niels Lofgren in the year 1943-42. I think there was a co-worker with him called Benge Lindqvist or someone, they're Swedish scientists. And this is something that is, the standard thing. There's nothing better than lidocaine till such time that you hear me coming in future. So lidocaine has been there for years. It's been nearly, 70 years that it's been there, right? So basically, if you talk about, how you will describe what is the definition, there are many definitions, but the most common one which we use is the reversible loss of sensation. That's very important. It's reversible. Where even if you give general anesthesia, it's reversible, but it involves a lot of armamentarium. It requires a lot of specialization, which need not be there, but you need to be trained in local anesthesia. So that is the reason why you need to attend, the clinics, you attend the lectures, because certain times there are something that can go wrong, something that can go awry, which I'll be dealing in a little while, right? So the pain management depends on 4 P's. The first P is the patient factor, right? Where you have anatomy, age, weight, comorbidities, and allergies. Now here is one, comorbidities. We have just come out of the second wave, and there are so many patients who would be on steroids, on blood thinners, patients who are really not fit to undergo any sort of procedure right now. Okay. The other thing is patients who are cardiac patients, patients who are on hyperthyroidism. These are patients where you need to exercise all the precautions. Okay. And those patients with allergies. Usually what happens is we Indians are a very hardy lot. Then usually nothing happens to us, right? But in the West, there are a lot of, documented allergies to even safe agents such as lidocaine. Basically, what we see is that it is the preservatives that are used in lidocaine that cause a problem, like methylparaben, chlorbutol, whatever. These are the agents which cause a lot of problems. The second one is the practitioner's technique. So that is important, how you learn to administer. And I'm sure there are many skill labs in various colleges and other places. Like we have a mannequin where we can demonstrate how you give a block and how you give the right block, how you perform extraction. So these are very important. You increase your skill, you hone up your skills, sharpen your skills. That's very important. The third P is the product. Now, this product would, what kind of molecule is used for what procedure. If it's a simple short procedure, you need to just, relieve an abscess intraorally. You can use something which is very short acting. If there's a longer duration, then you need to use lidocaine or articaine. And if you expect that the pain is going to be there for a very long time, you need to supplement it with bupivacaine. The last P is procedure. What sort of procedures we are doing? Now, if you look at it, because time is money, so everybody wants to get their job done at one go. So you have multiple extractions, you got, single sitting implants, you got implants placed everywhere. So all these things, they take, that requires which product and to use for which procedure and how much time, right? If you give bupivacaine for a small procedure, you're doing scaling, and if you give bupivacaine, the patient is going to have this annoying numbness for a very long time. And if you use something, a short duration local anesthetic just for controlling pain, when you've done a very difficult impaction, I'm sure you're going to end up with problems. So that's very important. Now, this is the regional anatomy, which you should know very well about. I'm not going to talk about it, but you should know where to inject so that you get the optimal local anesthesia for very predictable results, right? So the uses are it's got a lot of applications for extractions, for root canals, for implants, for small mucogingival surgeries or things like a small mucocele. We use it even for fracture reduction, simple fracture reductions, right? Because otherwise, I'm practicing, my college is in a rural area, semi-rural area, right? It's in Nagpur only, but it comes under the Grameen Bhag. So what happens is that the patients, they're basically laborers or industrial workers. The rich people won't come here. They'll go to private nursing homes or hospital. So what we do is, because they don't have all that money, we make the patient comfortable by using local anesthesia. And here is the case of abscess, which is drained under local anesthesia. So the ideal properties of local anesthesia is that it is potent, it is reversible. This is something very important. Reversibility is very important. If it is not reversed, then obviously you damage the nerve, right? Because the local anesthesia is reversible. You managed somehow to damage the nerve fibers. It is non-irritant. It should have a low degree of systemic toxicity, free from allergic reactions. It should have a rapid onset, low cost, and either being sterile or capable of being sterile. Now, which local anesthesia to opt for? If you go through these books, these textbooks, which are basically written by Western authors, there are a lot of molecules which are available. But in India, we have a very limited spectrum, right? So I'll come to that in just a while. So basically, if you classify them, you have amides. This is the workhorse, right? You got lidocaine, articaine, bupivacaine, and mepivacaine. Now, articaine is not a pure amide. It has got a little bit of ester in it, right? And that is actually responsible for how well it works, right? And then you got esters, which is, esters of PABA, which was procaine. We have quinolone derivative, which is senbupridine. Now, senbupridine has unfortunately fallen out of favor. But if you were using senbupridine at some point, somewhere in the early 2000s, you need not add a vasoconstrictor to it. It was a vasoconstrictive local anesthetic, right? So basically, we are working somewhere over here. This is the most common one that is there. So first is the length of procedure. If it is a short duration, you can use 2% lignocaine without vasoconstrictor. Now there are certain clinical situations also where you need to ensure that you don't use a vasoconstrictor, such as a patient who's recently undergone a bypass surgery or an angioplasty. So in such cases, it is better to avoid vasoconstrictor because that may cause coronary vasospasm. what the doctors would say or the physician would say that don't touch a patient before 6 months, 6 months preceding succeeding the angioplasty, which where cardiac procedure was done. But then sometimes, you have to work on a patient. What happens if the patient has got cellulitis or the patient has got acute periapical abscess? So in such cases, you need to do something. You need to provide relief to the patient. So the best is that you work in a well-controlled, well-monitored place, such as the hospital, where the patient has got treated for his particular cardiac case, right? If it's a short duration, maybe under 1 hour, 1:100,000 epinephrine or 1:200,000 epinephrine. Intermediate duration, 90 minutes to 2 hours, you can use articaine. You can also use lignocaine with 1:80,000, right? Mepivacaine is a good local anesthetic for those patients who got cardiac problems. So this is something we can use. It was there in the Indian market, but then it has been withdrawn by Septodont. So it is not very freely available. And for long duration, you got 0.5% bupivacaine. Etidocaine again is not available in India. So bupivacaine, you can supplement it. You do not use it as a primary local anesthetic. You can supplement it as a pain control mechanism after you do your surgery. Now, when you talk about hemostasis, right? The use of vasoconstrictors. So if you look at the lumen of the vessels, this is a normal artery, okay, with the muscular layer. This is a vasoconstricted artery. Now, why do we need vasoconstriction? When we need the anesthesia to be there for a longer time, you make it more potent, get better depth of anesthesia, you need to vasoconstrict it so that it stays there for a longer time. And this is a vasodilated vessel. I will talk about it nearly at the end of the lecture, why we need vasodilation sometimes, right? So the vasoconstrictors, they counteract vasodilation, decrease the blood flow, lower the anesthetic blood level, decrease the risk of toxicity, increase the duration of action, and decreases the bleeding, right? So these are the advantages. Suppose you want a bloodless field. So you're doing an implant, multiple implants, you're doing extraction, need a bloodless field. So you can safely use vasoconstrictor provided that the patient is, ASA1 or ASA2. I'll talk about it in just a while. The duration of the desired effect, physical condition of the patient, desire to achieve hemostasis, and concurrent medications. You need to be sure that what the patient do not. In the webinar that was there on 19th of June, there was a slight, difference of thought, and that is the best part. You need not agree 100% as to what has happened. I, for one, especially medical legally, because the patients would say that हमने तो बताया था, आपको देखना चाहिए था क्या है करके. It is better to consult the patient's physician or the cardiologist, okay, if the patient has got a cardiac issue. Okay, don't say that, oh yes, I know that by not stopping ecosprin, I can work on it. But then if something happens to the patient, because after all, life is more important than a tooth. So if the patient loses the life or has to be hospitalized, obviously the patient and the patient's relative will blame you. So it's very important that you should always consult the physician before you start any treatment in such cases. So these are certain precautions that you need to take. In congenital heart disease, vasoconstrictors need to be kept at a minimum, right? You can stop it also, but then everything should be done with the patient's, the pediatric cardiologist or the pediatrician. In rheumatic heart disease, minimal vasoconstrictor. In coronary heart disease, I told you that don't use it, right? It should be best avoided. Do not use it. In congestive heart failure, it should be minimal or omitted. Diabetes mellitus, minimal or omitted. So now here we have a situation, because in most of the post-COVID patients, because they were administered steroid, or maybe because the COVID has induced it, you need to be sure that those patients who are not diabetics prior to COVID, you better get their blood sugar checked, right? Because unnecessarily you will be subjecting them to some kind of problem. And in those patients who are hyperthyroid, you need to completely avoid, because there can be something that's worse than a coronary heart disease, that the patient can go into a thyroid storm and can collapse in the dental office. So the basic armamentarium that you need is topical anesthesia. This is for painless dentistry, sterile cotton tips, gauze sponges, needle shield or a recapping device. We'll come to it later. A sterile syringe, anesthetic cartridges, and appropriate dental needle. Now, we have not really got used to using cartridges. It's a very good thing, right? For 2-3 reasons. Firstly, you can make it, you can render it sterile again and again because they're made of stainless steel, surgical grade. And then the newer ones, the newer cartridges, they are aspirating. Earlier, the cartridges could not get aspirated. That was one problem, and that is why many people still don't use it. They use the regular dual-lock syringes. So it's very important that you aspirate before you inject. Which molecule? You just come to it. As I said, 3 of them which are used, right? So we have this lignospan and the septanest, which is septocaine, which is there, which is articaine, right? So you can use it. It's available. These are basically in cartridge form. You can buy cartridges of any company. It doesn't matter whether it's Septodont or whichever, right? So lidocaine, time and again I'll be referring to this as the workhorse. Absolutely, the old faithful never lets you down, right? Unless you are using a wrong technique or an expired solution. So it's an amide. Therein lies the safety. It's more vasodilating than mepivacaine. That is why vasoconstrictors are added. The pH of the plain solution is 6.5 with the vasoconstrictor is 5.5. So that makes it more acidic, right? The onset of action is 2 to 3 minutes, which is pretty fast. Do not start working the minute you take out the syringe, from the patient's mouth. Let it act. You can use certain measures to improve the spread of it, how it gets absorbed. It's pretty good the way that you do it. Effective dental concentration is 2%. Now I believe that there are third years and final years, right? It's very important, and this is a viva question that is usually asked. If a 2% solution is being used, how many milligrams are there? So number one, it is 20 milligrams per ml. Okay, even if you're using a vial, which is 30 ml, so it is per ml that is counted. So 2% solution will have 20 milligrams. Depends from manufacturer to manufacturer. It can be 20, 21.3 or 24.64 milligram per mg per ml. So that's very important. So biophase. Now, why are we stressing so much on the amount of local anesthesia? I'll come to it later, but basically you need to be sure that you're not injecting more than required, right? That's very important. You cannot go beyond a certain limit because that will cause toxicity. The second thing what happens is you have to be sure on how you inject because the facial vessels, they are usually valveless and even a small amount can enter the cerebral circulation. It's got an anesthetic half-life of 90 minutes, so that means between 60 to 90 minutes you're pretty good to go. The advantage of amide is extremely rare incidence of allergy. Lidocaine comes in plain 1:50,000 to 1:450,000 epinephrine, right? Epinephrine is same as adrenaline. So 1 in 50,000 epinephrine is not dangerous, but in some patients such as ASA 2 and 3, you need to use it with precaution. Now here comes up, the dilemma. If the patient is a cardiac patient, if the patient is hypertensive, would we use adrenaline or epinephrine? Yes, you can. If the patient is moderately hypertensive, you can use about 4 ml solution of 1:100,000 epinephrine because that works out to somewhere around 0.004 mg, right? Why it is important to use epinephrine in such cases is that the anesthesia stays there for a longer time. So if you planning to work for a longer time, about an hour or an hour and 10 minutes, the anesthesia stays there. You need not keep repeating anesthesia, therefore preventing toxicity. So that is the importance of using epinephrine in moderately hypertensive patients. So never say that you can't use. However, the rider is that if the patient is, quite a patient has got recent angioplasties or bypass done, then better to consult the physician, right? Articaine, this is a relatively newer one which came into existence somewhere in the 2000s, right? The major advantage is the thiophene ring, and this thiophene ring, we need not see what it is pharmacologically, but the thiophene ring means that it can enter the bone nicely. Therefore, the major advantage of articaine is that when you are carrying out extractions in the maxilla, you need not give the very difficult or very painful palatal injection which you use for retraction of the palatal gingiva, right? So that is the major advantage over here. In young patients, even the mandibular molars can be extracted just by giving a infiltration anesthesia, because in pediatric patients the bone is porous, so it diffuses very well. Okay, so that is the advantage of using Articaine. And believe me, if the patient does not need a palatal injection, he's going to refer 6 patients to you. Okay, so Articaine, there were many studies were done. Potency wise, they are more or less absolutely similar, but then safety wise and the way it acts makes Articaine a very popular solution, or an upcoming popular solution as which is there, right? And of course the safety profile, because the amides are degraded in the liver by hepatic microsomal enzyme E450, whereas the esters they were degraded by the pseudocholinesterases. So that is why Articaine has got very rapid degradation. You are safe, the patient is also happy, right? So the benefits of Articaine versus lidocaine, well, can use whatever you want. But then if you look at the advantages that it offers, especially for the maxillary teeth, you're doing an orthodontic extraction, those patients are young. So in such cases, it's better to use Articaine. The flip side of using Articaine is that, they are available only in cartridges. So that is the way it is made. And that is also a safety feature, because when you are using cartridges, there's no need to add a preservative. The only thing that is added is EDTA to prolong the life. Even for lidocaine, EDTA is added. You can use it very safely. I'll just show a couple of videos to you. You know them very well. You're working in premier institutes in Delhi and all over North India, so you can, you know how it works. But I'll just show you a couple of small procedures which will make your understanding better. Okay.
This is the ramus of the mandible. This is the anterior border of the ramus.
I hope you can listen to the audio
The
of
anterior border of the ramus features a concavity. This concavity is called the coronoid notch.
This is the coronoid notch on the anterior
We
border.
start our block by identifying this coronoid notch by means of the thumb. The height of the injection coincides with the midpoint of the
It's somewhere over here.
fingernail.
Yes. This is the point where your needle should bisect the thumb and enter the target area.
The patient is asked to open her mouth wide open. The coronoid notch of the anterior ramus of the mandible is palpated. As noted earlier, the height of the injection coincides with the height of the fingernail tip. The next step is to identify a soft tissue roll in the oral cavity called a pterygomandibular raphe and denoted by the red arrows. The identification of this raphe is critical for the success of this block procedure.
Now, what is to be noted here is that this pterygomandibular raphe, right, you need to identify it very well. So that's why you need to do more and more patients, because no patient come with pterygomandibular raphe written in his oral cavity, in his or her oral cavity, right? So you need to be very sure where you are injecting.
Just lateral to the pterygomandibular raphe, there is a depression called the pterygomandibular depression. Right now, the cap needle is inserted into this pterygomandibular depression so that you can identify it clearly.
What is being used here is a cap needle. It's called a safety sheath needle. Not many, I have not used them, so I can't vouch for them. So that prevents needle stick injuries to the operator.
The intersection between the line we drew first from the height of the nail tip and the pterygomandibular depression. Right now, the needle tip is in the exact entry point. Here is a live block demonstration. The index of the non-dominant hand is rested into the coronoid notch of the anterior ramus of the mandible.
Am I audible?
Yes, yes.
The needle comes from the contralateral side, from the corner of the mouth, and it is inserted into the pterygomandibular depression and advance for 20 to 25 millimeters until bone is contacted. Once bone is contacted, the needle is
Am I
withdrawn
audible, Deborah?
slightly.
Yes, Dr. Shenoi.
Then injection
You are audible, sir.
of
You are audible,
2/3
sir.
to 1 cartridge of local anesthetic is performed after negative aspiration. Then the needle is withdrawn.
Sorry. This is the other. Professor Sanjay, can you hear me?
Yeah, very clearly, Dr. Shenoi. Dr. Shenoi, you are heard very clearly.
I don't seem to hear myself. I don't know what has happened.
There is some issue with your, it must be a local issue. You are heard very clearly, Dr. Shenoi. You are heard very clearly.
I can't hear anything.
Sir, you can call him, sir, over phone.
We can hear you very clearly. Your audio and videos are perfectly well.
Hello.
You are heard very clearly, Dr. Shenoi. Don't you worry about that. Yes.
Okay.
Yes.
Okay. Because I can't hear anybody speak.
Okay.
Okay. Great. Okay. Okay. Thank you. So I'll just continue now. The second video that I'm going to show is Professor Malamed's video. They're available on YouTube. Anything is available on the net. But I'll just show you a couple of videos. Now, this is the infiltration technique, the first one.
Maxillary teeth. The area anesthetized is the pulp and the buccal soft
What you
tissue
see
and
over
bone
here.
of the tooth anesthetized. The
And
recommended
what
needle
it is going to
is a
anesthetize
27
is,
gauge short. The insertion site is in the height of the mucobuccal fold over
a
the
small part.
apex
So you
of the
basically
anesthetized tooth.
infiltrate closer to the
The
apices
needle
of
is
the
held
teeth rather than
parallel to
going
the
close to the
maxillary
nerve.
bone and
Right.
inserted until the needle tip is at or above the apex
So it's
of the
very
tooth.
important how you position yourself and how it is injected. Aspirate
After
and
two
inject.
negative aspirations,
What happens is, I would like to aspirate, if I'm injecting 2 cc's of solution, what I'll do is I'll aspirate, I'll inject. Then I rotate the barrel quarter turn, aspirate, inject. So if for every quarter turn, if I deposit 0.5 ml of solution, at the end of 4 turns, I am aspirated 4 times and I am injected 2 cc's of solution. What happens is that the risk of injecting in the vessel has gone. I mean, you are sure that you are not in the vessel, and by being sure that you are not in the vessel makes you safe that nothing is going to enter the cerebral
1/3 of a
circulation.
cartridge of local
So this
anesthetic is slowly injected.
Again, now this is something
The
that we use
posterior
very often.
superior
The
alveolar
posterior
nerve
superior
block
alveolar
provides
nerve block.
scopal anesthesia
Right.
to the
Most
3
of
maxillary
the
molars
procedures
and the
nowadays,
supporting buccal soft
they're
tissue and
done
bone.
in a sitting
In
posture.
28% of
So
patients, the mesial buccal root
it's
of the
very
first
important
molar
that we
may not be
position ourselves.
anesthetized. A 27 gauge short needle is for the left PSA nerve block. A right-handed operator should sit at the 10 o'clock position
So you're on
facing
a
the
10
patient.
o'clock position.
For the right PSA nerve block,
Right side.
a right-handed operator should sit at the 8 o'clock position
8
facing the
o'clock, sorry.
patient.
10 o'clock for the left side, 8 o'clock
The
for
insertion
the right
site is the height of the buccal fold adjacent to the
And then
maxillary
you
second molar.
aspirate.
The syringe
and
is
inject.
held in an
The
upwards,
direction
inwards, and
is,
backwards direction
you're going
and is inserted to a depth of 16
superiorly,
millimeters.
medially, and backwards.
After 2 negative
Right?
aspirations,
So this is
a half a
a
cartridge
couple
of
of
local
techniques
anesthetic
that you ought to know. Now we talk about, if I can just talk about for a minute about the nasopalatine nerve block, right? What you can do is, it's one of the most painful blocks that you can give because the palatal mucosa is unyielding. So what you can do is you can apply a topical local anesthetic, or you can give a small little bit of local anesthesia within between the two central incisors, so that there's a preparatory infiltration, and then you inject inside the foramen. And that is what you do. Now, another thing which I'll be coming at the end of my lecture is that how you can give painless injections by using simple techniques. That's how you do it. You need not use complicated methods such as single tooth anesthesia or wand or CCLAD, which are pretty expensive. They're only practice building measures, right? This technique is the Bhajirani Aquinoce technique, which is used for giving for periodontal anesthesia to the lower molars, right, up till the premolars. You can do this. This is helpful in those patients who are slightly scared of getting injected, or to those patients who have a limited mouth opening. So what you do is you make the patient close his upper and lower teeth, and then you insert the needle with the syringe kept parallel to the upper gingiva, right? When you do that, you are sure near the inferior alveolar nerve. We need to be proud about this technique because Bhajirani was an Indian dentist who devised this. So that's why it's not an Italian name, but an Indian name, Sundar Bhajirani, who devised it. So we should be proud of it, our Indians. What happens basically when we give a classical inferior alveolar nerve block using the technique which I showed in the first video is that it has got a high rate of failure, and that failure can be somewhere between 15 to 25%, which is pretty high. So it works only for about 75 to 85% of patients. Now, if you want a sure shot anesthesia, one can use the Gauguet's technique. Now, this was devised by Dr. George Gauguet, who was an Australian dentist, right? The only hitch is that the patient needs to keep the mouth wide open, right? And we have a worry why this technique has not gained popularity is because this technique has got a little worrisome, the target area is very close to the internal maxillary, the branches of the internal maxillary artery. You're a little bit worried about it. It has got a steep learning curve. You can't do it just like that. It's got a steep learning curve. So practice on mannequins before you do it on a patient, right? So that is how, and this particular technique, Gauguet's technique, has got a 95% success rate. So that's the best part about it. Now, this was one very recent article that we published in the Journal of Oral Biology and Craniofacial Research, where we have used a technique. Now, what happens is when you're giving an infraorbital nerve block, right? The problem is that you need to have teeth. And what happens to those patients who don't have any teeth? You can't have a bicuspid technique in an edentulous patient. So what happens is that we direct it close to just below the piriform aperture and in line with the infraorbital rim. So you strike the bone and you're sure that you've got the nerve anesthetized. So that is the major advantage of this particular technique. There are other techniques, but unfortunately, all of them use the presence of teeth as a landmark. This particular technique does not need teeth to be present. Now, this particular, you can take screenshots, or I think Dr. Sanjay would have it on the YouTube channel of the journal of the university. So these are the various areas. The colored area shows which all areas have got anesthetized with which nerve block, right? So you need to know the anatomy, which I talked about in one of my first slides, and then keeping that anatomy in mind, when you inject, which teeth are going to be injected, which teeth are going to get anesthetized, and which others you need to infiltrate or inject more so that you can get a good result. So that is the major advantage of using local anesthesia. Now, failures are a part of life, right? And those who don't do and boast that they have not got any failures, have not worked, it does happen many times. I can share a lot of experiences which I did, and I'll do that in my subsequent slides, right? And some of them stem from from my days of post graduation, where local anesthesia would not act in a particular patient. Back in those times, in the in early 90s, if local anesthesia didn't work, Sanjay, and we use vocal anesthesia. But nowadays you can't do that because the patient is going to use something else on you. So you have to be absolutely sure that your anesthesia is working, right? What we found out in that patient in my post-graduation days is that he had a bifid mandibular foramen. So what used to happen was that the nerve did not get coated with the local anesthetic solution, and the patient constantly screamed while we were working. So it's very important. If it doesn't work, then I'm sure that, and our technique is proper, maybe we need to subject the patient to some investigation why it's not working. The first part is the use of outdated or contaminated solution. And the best way to do away with this is, to use cartridges, because cartridges have got, they do not have the problem of getting contaminated. They can be outdated, of course. You cannot use a cartridge which is 5 years old. Okay. So make sure that there is no contamination, and contamination happens because of this. If you see this, this is the usual thing which we find in our clinics, with the needle inserted in the vial. And unfortunately, what happens is we need a second dose to inject in the patient. God knows what all is going inside, because we are using the same syringe. Okay, we do not even change the syringe to draw the local anesthesia. So make sure that, every time your assistant hands you local anesthesia, ensure that you check on the bottle the expiry date, right? Even if you bought it yourself, you need to check the expiry date, because we live in an era of medical legal issues, the Consumer Protection Act, and not just that. Why not do good ethical practice? So we need to be very sure about what we are using. The other three things are, if you are not allowing sufficient time for it to diffuse, like I said earlier, it takes about 2 to 3 minutes for the local anesthesia to act. So don't be in a hurry. Even if you've got a multi-chair practice, don't be in a hurry to set up your work on your patient immediately. It takes time. Sometimes it takes more, because there could be some patients who are like alcoholics, right? It's going to take a lot of time for the local anesthesia to act. The wrong anatomical position, that means you're not palpated the landmarks, you're not sure about where your needle is going. You can enter the parotid, you can enter the somewhere close to the absolute anterior border of the ramus of the mandible, and that can cause problems. Insufficient solution. Oh, sir spoke about toxicity even with 1.8 ml of solution. I need to be careful. But then, if you are giving the block the right way, I'm sure that it's not going to cause any problem. 1.8 ml, 1.8 ml to 2 ml is absolutely fine to use. One thing is, when you're using Articaine 4%, it is a 1.7 ml cartridge. That 0.1%, I don't know why there is a difference, but anyway, it is there. Injecting in an inflamed tissue, right? So what happens is that the pH of the solution is slightly acidic or a weak base. This area is acidic. So when you inject over here, it's not going to act. So first thing is ensure that it's not an acutely inflamed area. And even if you have, you can do certain things in your own clinic which can make it more basic so that it diffuses in a better way. And I'm going to talk about it in just a while. So the failures could be wrong technique, there could be pain, anatomic aberrations, I just talked about it, inadequate volume, presence of infection, again it's there, operator inexperience. So please work on mannequins, please work in your clinics whenever you are there as interns, as students, make sure that you get adequate practice. And since you are in Jamia Millia, I'm sure that there's no dearth of patients. Psychological issues. Now, there is something very important. There will be patients. I still have a patient for whom to remove a molar, I need to work in general anesthesia, because every time you inject, she says that it doesn't work. Your technique is perfect. You have used different techniques of administering local anesthesia, the classical technique, the Bhajirani Aquinoce technique, but still the patient says that no, it doesn't work. So in such cases, it is better to calm the patient, and you can get to work in a controlled or monitored situation such as the hospital, where you can have an anesthetist to administer general anesthesia. Now, this is something which we come across very often, and usually this is more seen in the root canal treatment cases, right? So you have the core and mantle fibers. So the core fibers are obviously inside the core, and you have got the mantle fibers which are on the outside. So if you section a nerve, right, and observe it under microscope, you see fibers all over, and the core fibers are responsible for the pulpal and periodontal anesthesia, right? So you need to ensure that you give the right technique for this. So this is something which we come across very often. So especially as rookies, every time you inject a patient and you ask, "Dukh raha hai kya aapko? Dukh raha hai kya kaka? Dukh raha hai kya mausi aapko?" The patient will say yes, because the patient is not able to discern between pain and pressure. And pressure is the last thing that goes away. When you're administering local anesthesia, the pressure is the last thing. So when you're extracting a tooth, it is not possible that, all of the pressure symptoms go away. So you need to explain to the patient. Don't ask the patient. Always observe the patient's reactions. The patient may shrug, the patient may blink the eye. So these are signs, which tell you that, the patient is having pain. If you ask the patient, every patient is going to say, yes, mujhe dukh raha hai. So you need to be sure about what you ask. As I talked about in my previous lecture about low pH, right? So you can buffer the solution. Now, why has it not got popularity? The thing is that you do not get commercially prepared buffered solution. The local anesthesia precipitates. I'll talk about, it's very simple. You need to add 1.5 ml of sodium bicarbonate to 10 ml of solution. And then the best thing is if you have a patient bunched up, then you can use it. If not, it's not possible, in dental clinics to have such a thing done. Having said that, when I went through literature yesterday, there are certain devices which are available, and I'm quite sure that they're going to cost a bomb when they come to India. So maybe that's why they've not come at all. There are certain commercially available, not local anesthesia solutions, but you got a cartridge of 3 ml and you use the 1.8 ml cartridge. There's a special kind of a pen which is there. It looks something like this. I'm not exactly this. So you, on one side, you add the cartridge of the buffered the sodium bicarbonate, and on the other side your regular cartridge, and then mixing happens somewhere in between. You've got to set the dial and all. So unfortunately, what happens is that they will be pretty expensive. So that is why they've not gained popularity in India, and neither has the regular buffering. Because if you want a 7.5% solution, you need to do this. And if you keep it long, then the local anesthesia precipitates and it renders it unavailable. What happens is that when you're using a buffered solution, the pain on injection is reduced. When you deposit the solution, that particular, the turgidity that it has on the palatal mucosa, that particular sensation is gone. So obviously the patient is more comfortable. Now it's good for studies. Now this is, Professor Sanjay, this is there are references in the literature about use of hyaluronidase, right? Like this one. Unfortunately, the use is not very much confirmed or whether it is beneficial, because why do you want to keep adding pharmacologic agents, just to ensure it's spread? Maybe you can have an untoward reaction to hyaluronidase. So the thing is that, these are certain reasons why they don't gain popularity. If you are sure about the technique which you're using and how you're using, right? If you have the anatomical landmarks in mind, I'm sure that you're not going to need any such thing other than the routine part. So as I come to the final part of it, the complications, you can have local complications and systemic complications. Any deviation from the normal expected pattern is called a complication. You are going from Nagpur to Delhi, and unfortunately you end up somewhere near Surat. That means it's a complication. You're deviating from your path. So you need to be sure about which path you're taking. We have written a series of articles in the Famden Journal. I think in this series it was totally on local anesthesia. They're available from 2018 to 2020, right? So the local complications are needle breakage. So ensure that you're using fresh needles all the time, right? And you're using the right gauge of needle. A 27 gauge needle is good enough, right? Don't try to use a 30 gauge needle because it is a very fine needle to give a pterygomandibular nerve block, because there's a risk that it will break off. If it breaks off at the hub of the needle and you find the needle protruding, try to remove it without manipulating too much. If you can't see it, refer the patient to a max fax, right? Because if you try to push it further, there's a risk that it goes to places where no one can locate it very easily, right? So make sure that you use good syringes, good company syringes. Don't use substandard syringes. I remember again, if I go back to my PG days, we used to use those glass needles with the stainless steel the glass syringes with the stainless steel needle. And unfortunately, the patient load was so much that you would not care whether it has got a barb or something. You just kept injecting. The patients didn't complain, but times have changed. You should do good practice, right? So use fresh needles always. But this was a case which we reported in that particular journal, and this was a case which was done in one of the departments, and then whichever complication it has, people come rushing to MaxVac. Now, my plea is that everybody should be able to deal with such things. It can happen to anyone. I remember a case myself in my clinic, and the patient was a cardiac patient, was on blood thinners, and despite the fact that I gave a PSA nerve block, keeping all the landmarks in mind, unfortunately being a blind procedure, the patient suddenly had hematoma. The only thing that has to be done is to give immediate pressure, give pressure intraorally between the ridge and the cheek, and then extraorally, you can place a, if you don't have a cold pack, you can just place a firm gauze pack over there, tell the patient to hold it, right? So that you do not end up with this. I had a colleague who every time he used to inject in the PSA, he used to tell the patient immediately after injection, he used to tell the patient to do like this. So even if there was a chance that, there was a minor rupture of the pterygoid plexus, the patient would not have a swelling. So all that needs to be done is just to keep a firm pressure if it happens. The only thing that is disturbing is, the patient after 14 days comes to you with a blackish discoloration, and that is what worries the patient. The patient is not too much concerned about the swelling. The patient is worried about this discoloration. This happens because the RBCs which were there, which got extravasated, they are in the tissue planes now and they are undergoing hemolysis. So it's a self-limiting thing. The patient will be fine in 3 weeks, right? You need to just reassure the patient. These are transient complications that can happen. My favorite question, if I showed this slide during an exam, would be which area has got affected, whether the dentist gave a block on the right side or the left side. So obviously it is the left side, okay? And that went into the parotid because care was not taken to hit the bone when you are injecting. Once you hit the bone, you are sure that you're not going posteriorly. If you go posteriorly and deposit, then you are in the substance of the parotid, and that particular thing causes the diffusion of the local anesthetic solution and causes facial nerve paralysis. So obviously the left nerve has got paralyzed because that's transient, because the patient can close the right eye. Trismus, soft tissue injury, pain on injection, we just talked about it. Trismus happens when you damage the medial pterygoid muscle, and usually you need to be sure about how you inject. Can numbness be reversed? Yes, it can be. Unfortunately, again, Oraverse is not available in India, at least not in Maharashtra, I'm quite sure. I don't know whether you can get it in Delhi or NCR, right? So this is phentolamine mesylate. Phentolamine mesylate was used as a vasodilating agent, right? An antihypertensive drug because it's got alpha adrenergic antagonist. So from dose of 0.4 to 0.8 for adults and half of that in children is proved to be safe and effective. Why do we give that? Because young patients are not able to understand the numbness, and there's a risk that the patient may bite the lip, and that can cause grievous injuries to the patient. So it is important that the anesthesia be reversed. So when you inject this particular cartridge of phentolamine, it's going to cause vasodilation in that particular area. The local anesthesia is going to be rapidly absorbed. Right? Systemic complications, again our article. So syncope is the major one. So you got fright, which is psychogenic factors, anxiety, emotional stress, unwelcome news, the sight of blood, surgical procedures, instruments, etc. Now there's a third year syndrome. I am sure that everybody would agree. You come to the third year, you see some surgery going on or an extraction going on, which you may feel that it's brutal, and then the student, unfortunately, the student kind of faints. So that is basically a psychogenic cause, which is easily reversed, and just come to it. And the non-psychogenic part is basically something that would make the girls happy, right? I'll come to it why. So you got sitting in an erect and standing position. This happens to the, to a lot of people who are there, such as who need to stand for a long time, such as the policemen and all, right? Hunger from dieting, exhaustion, poor physical condition, hot, humid, crowded environment. When we go to a discotheque or a nightclub, we're very happy, no matter how many people are there. But the same number of people in a DTC bus or the metro would make you, curse everyone that there's so many people in this particular sitting. Here. Male gender. Now, why am I talking about male gender? Because when a dentist is holding a syringe like this, in the hand, it looks menacing, and so are the instruments. The basic reaction would be to run away. Okay. Now you can't run away because you want to show that you are a man, you are a macho man. So you have to sit there. There is, by reaction of the body, there is pooling of blood in the peripheries. Okay. And thus depriving the brain of the vital oxygen that comes with the blood. So that is why people between the age of 16 to 35 are the usual ones who go into syncope, right? The only thing that has to be done is the posture, right? So this is the pre-syncopal phase where you got the fear, the patient faints, and the recovery phase. So what you need to do is you have got to ensure that the head, the thorax, and the trunk are in one plane. Contrary to what people say, do not do a Trendelenburg position that is making the patient head low. It doesn't help. The pooling of blood is in the peripheries, right? So making a head low does not improve the circulation. All you need to do is to raise the legs, make the patient move the limbs, the hands just like this. So by muscular action, the blood is going to get pumped back into the heart and therefore to the brain. So do not do a Trendelenburg position for this. So assess the basic algorithm would be assess the consciousness, discontinue procedure, do not keep working. अरे आप तो बहुत अच्छा cooperation मिलेगा करके नहीं करने का, right? Activate the emergency team. Position A, B, C, right? Definitive management. If the patient fails to get revived, then you need to administer oxygen, monitor the vital signs, and give atropine 0.6%. Now this is a part of your emergency kit. Emergency medical emergencies in dental practice is a totally different topic. I'm not going to go into the details of it. What is important here is toxicity, right? So toxicity looks something like, having a seizure. Everything is just the same. So what happens in toxicity is that if you keep injecting, if you do not aspirate, the local anesthetic solution is going to go into the brain, and then it can lead to tonic-clonic convulsions. So it's important that we know that we cannot administer more than 7 milligram per kg body weight of local anesthesia with adrenaline, okay, and 4.4 milligram per kg body weight without adrenaline. This is to say that if a person is 100 kg, you cannot inject 700 milligrams. You cannot go beyond 500 milligrams. That has to be kept in mind. So that's why they say that 500 milligrams is the maximum, because they're calculated on a average individual who weighs about 65 to 75 kgs. So the symptoms of systemic toxicity, as the dose increases, you'll find dissociation, AV dissociation, bradycardia, myocardial ischemia, and ultimately a cardiac arrest in those cases where you see CVS symptoms. And in CNS, the patient will end up with, ultimately the patient will end up with respiratory paralysis and death. This is something that is not something which you want in your dental clinic. So please make sure that you know how much you're injected. Keep a count if you're injecting multiple doses. What you can do is, if you're working on all the 4 quadrants, finish one quadrant, then go to the next, then go to the next, right? You need not inject all the quadrants at the same time, and then you find that quadrant number 3 again needs to be injected. So you're increasing the local anesthesia. So important is position, airway, breathing, circulation, and definitive. If the patient fails to revive, right, do not try to make the patient smell his shoe or your shoe. If it doesn't smell good to you, it's not going to smell good to the patient. You can keep, don't try such thing. That was for syncope. But over here, you need to give the patient some injectable benzodiazepine, such as diazepam, okay? And that will take care of the tonic-clonic seizure. But hopefully that you don't reach to that stage. So from painless, painful to painless, You've got different devices. These are vibrotactile devices. So you got the small fibers and the large fibers. So basically what will happen is that when you use such devices, they vibrate. When you inject, they vibrate. You can clip them onto the syringe. So what happens is that the large fiber stimulation happens and the patient does not feel the pain, right? There are conflicting studies that have said that they may be good, they may not be good, but then you can always use them. This is the Horizon, the computer controlled local anesthesia delivery system. It was introduced in 1997. It's a very lightweight handpiece which is there, and it will give only that much which is required because it is pre-programmed. Okay, so there are pre-programmed like block infiltration, PDL, and intraoral and palatal, right? So it gives very slowly, so you don't have a risk of toxicity also. Okay, the only thing is that they're very expensive. And the other thing is, I'm sure that there are practitioners also in this particular webinar. What happens is that you have an extra armamentarium which needs storage space, you need to autoclave, you need to make it sterile. So these are certain problems that can be there. So the jet injectors, what I have in mind is the sure shot system, right, which we are working as a part of thesis. I have got a video on it. This is something which is there. There are different types of jet injectors based on the types of mechanism that they have. So if you look over here, this is the regular syringe. And when you deposit the solution, you've got a bleb of local anesthesia here, right? If you are using a jet injector, which does not have a needle, you can see that, there is increased spread. So you are sure that you are going to coat the nerve very properly. The flip side, expensive, right? So this is a short video. I'm sure you are able to hear, but I am not able to hear myself. So
there we go.
I thought that, basically you could use it, you can use it only for infiltration, but in this particular video, they are using a block. So if you look carefully, when the patient opens the mouth, right, you can see a small red spot. That red spot is where the jet injector deposited the solution. It's going to go in a spider pattern. It's called the spider pattern.
5 minutes.
So this is what the doctor is looking for.
You can see a
this
very
red spot over here.
red mark.
Right? So that means
After
your
using the
anesthetist
injector.
has gone inside. And the patient, obviously,
We
on
are
subjective
going to test
and
the
objective
canine
symptoms,
eminence,
the patient was
which we
comfortable.
test
So
to
this is
make
probing
sure that the block
objectively
has
to find out the
canine
access.
eminence.
Okay. This is the system that we have here. This comes in a box like this. Okay. And this is how you charge it. I mean, charging means it's not there's no battery inside it, but this, I think the spring gets loaded. Then you adjust this particular area to incorporate the needle, the syringe. Sorry, this is the syringe, right? So this is what is there. We've got a plunger over here, right? And if you see, there's no needle on top of it, right? Absolutely, there's no needle at all. So when you do that, what happens is there's a cartridge adapter also, sorry, the vial adapter. And when you use it in the vial adapter, you draw the local anesthesia, which is roughly 1 to 1.5 ml, like this. Load it onto this, okay? And then you inject the patient. So now you are good to go. Slightly, it looks menacing. It looks like you're going to stab someone. Okay. So I think this costs somewhere around 14,000 rupees, right? So this is the cartridge vial adapter. This is all that is done. So the patient doesn't even realize it. So it's good for young patients, We are yet to master the technique ourselves. Basically, pandemic played a large part in making us not work on it. Twin mix is where you use local anesthesia with dexamethasone. Longer time, more potent, stays there for a longer time. These are the horizons. We're using an intranasal spray, and that ensures, of course, it has not come to India yet, right? So you can anesthetize the anterior superior alveolar nerve and the middle superior. So from incisor to the canine, you can work properly. So good practice would be, trying to ensure that you're using the right technique. Do not use such methods to trying to scare the patient. In Bollywood films, they'll be using the syringe and trying to expel the air from the syringe. Do not use that. The patient is not very thrilled to see something going to prick him or her. Okay. So make sure that you expel the air behind the patient. Whatever instruments you're using, especially the sharp ones, they should come from behind the patient, right? Your assistant should hand it over from behind the patient. That goes a long way in preventing a lot of complications also. So the painless injection technique is using a sterile sharp needle. Position the patient properly. Don't make the patient shift here and there or yourself. Use of topical anesthetic. Keep talking to the patient and then taut the tissues. What is tauting the tissue? I'll just show you. This is tauting the tissue, right? You stretch it. Now imagine, how easy it is to prick a balloon that is totally full and the one which has got very little air in it. So if you make the tissue taut, what is going to happen is that the needle is going to enter very painlessly. At the same time, you're able to visualize where you're injecting rather than just letting the lid droop over the syringe. Okay. So inject a few drops. Now that itself will cause relief of pain. Advance the needle, aspirate. I said 4 turns per 2 ml. Right. Slowly deposit the solution, withdraw the needle and observe and communicate with the patient. Don't turn your back to the patient and then start working on something else or doing something else. Right. So lastly, specialty wise anesthesia. In endodontics, you got infiltration, PDL, intrapulpal and regional block. I think I'm missing out on one slide here. That is the intraosseous technique, where you give a preparatory, infiltration in that particular area, and then you use you kind of drill a hole inside the bone and then deposit the solution over there, just below the apices of the teeth. For oral surgery, regional block and infiltration, and in pediatric dentistry, please make sure that you're not injecting the adult dose. The children they're not small adults. Okay, you've got to keep that in mind. So the take-home message is proper armamentarium, selection of the appropriate molecule. The landmarks are always to be kept in mind, the right injection technique and supplemental anesthetic measures. So you can have a successful practice. Now this picture was in pre-COVID times. Okay. So obviously you do not see a face shield, so on and so forth. And ये अभी COVID time में दूर की दोस्ती ही अच्छी है. So maintain a safe distance, right? Always use the right, the barrier techniques, which will go a long way in helping you and the patient. Thank you so much. You can get in touch with me on my Facebook. You can email me. You can WhatsApp me on this number. I would express my gratitude to Professor Sanjay Singh for giving me a chance to speak at this very, very prestigious institution and the university. Not everybody gets a chance to speak at Jamia Millia. Thank you, sir. I would like to thank the IT team. They've done a fantastic job. And of course, my residents. Now, Shruti Jain is a consultant in Raipur. Jignesh is in his 3rd year, ready to appear for the exam. And Septodont in India for certain slides that they gave me. Thank you so much for a patient listening. If you have any questions, Dr. Sanjay Singh will answer them. Thank you so much. Shall I stop sharing?
Dr. Imran will take over and he'll let you know.
Sir, it was a wonderful. Yes, sir. It was a wonderful lecture, sir. Thank you so much. We all enjoyed it, and I am sure our students and all the attending participants were enlightened. Rama sir, can you hear me, sir? Shenoi sir, can you hear me? Shenoi sir, can you hear me, sir?
I'm going to speak to him, Doctor. I'm just going to tell him to log out and log in again.
Yes,
you
sir.
log
yes,
out
sir.
and log in again. Log out and log in again.
Okay.
It was a wonderful lecture, Sanjay sir, and I think question and answers, because most of you you have been teaching local anesthesia, Sanjay sir, to our students many a time. So I think students will be more interested to ask questions directly to Shenoi sir, because because उनको आपका पता है कि क्या-क्या सारी चीजें कवर करी हैं. So maybe
that was just on a lighter side.
Yes,
he will be answering, no issues.
So dear students, in case if you have questions, please post the questions as suggested by Dr. Deborah in the chat box.
Sanjay sir, I had a query, sir. Can I ask a question to all the panelists?
Yeah.
Regarding the aspiration, can the aspiration done at the start of the before injecting in 2 planes and then inject, rather than injecting 0.5 ml and then turning the needle, then again?
Actually, what I will suggest, when you are in the final position where you need to inject, that is the time when you should be aspirating at least twice. That means once you give half turn, that means you have moved about 180 degrees. And if you are hitting the lumen of a vessel, because that vessel's wall is sucked in, then you turn it by another 180 degrees so that you are sure you are in the lumen of the vessel, if at all you are in the lumen of the vessel. So you are supposed to aspirate twice before you inject in the final position. That is how
we have been doing and what we have taught our students also.
Yeah, and that is the right way also, because otherwise you inject, supposing you are there in the vessel, you have already injected, so you not prevented your LA from entering into the artery or whatever it may be, a vessel.
And sir, I would also like to make one point here, while getting onto the final position, we all get onto the final position, we need to withdraw our needles by at least 0.5 millimeters, specifically with an inferior alveolar nerve block, because we don't want our injection. This is for the students actually. We don't want our injection to be injected directly below the periosteum, because periosteal blocks are generally painful. So this way you can reduce the pain if you slightly, after you hit the bone, just by maybe a 0.5 of the millimeter, just withdraw it, because we have a tightly adherent periosteum onto the bone. So we don't want our injections directly, going into the periosteum or subperiosteal deposition. To avoid that, we slightly retract. That is what I wanted to add, sir.
Shenoi,
that is the final position, Dr. Imran. When we say final position, it is once you hit the bone and retract. That is the final position.
Final position. Yes. This was just for the students, sir. Actually, students sometimes may have a misconception that final position is not the position where we hit the bone. So I just wanted to make it clear to them.
This can happen more often than not in inferior alveolar nerve block, because the bevel of the needle is such, it can go between the periosteum and the bone. The chances of a subperiosteal block is more in inferior alveolar. If you are going straight rather than going oblique, and subperiosteal block, because it is firmly adherent onto the bone, it will strip the periosteum of the bone, and the pain is because of stripping of the periosteum from the bone.
Very true.
Sir, Shenoi sir is back.
Is there.
Yeah, I'm back.
Shenoi sir. Sir, thank you, sir, for a wonderful lecture, sir. It was, enlightening for all the students and even enlightening for us. We all have been teaching local anesthesia for years now, but it was enlightening and it was a learning thing for us as well, sir. Thank you so much.
You've been very kind to me, Imran.
Sir, let me start with the question, a small query which I have, sir, if you allow me. Sir, specifically with space infection patients, suppose if I have a patient of a submandibular space abscess or a Ludwig's angina, and you know that we are all working in government colleges where generally OTs are not available very easily, we generally tend to do it under local anesthesia. And then there are anesthetic implications as well, where the anesthesia will raise his hand ki bhai local mein hi kar lo, bada mushkil hai intubation. So in those cases, what I generally do, I want to please correct me. I generally give a block, good block, high mandibular nerve block. I wait for at least 15-20 minutes. I wait long actually. And I tell my students that by waiting long, actually, you are allowing the anesthesia to settle down, and having the anesthesia set on better will, make the patient better. And then locally infiltrate wherever you are trying to incise or give an incision. Now, even after that, once we are below the dermis or into the subplatysmal level, specifically in the neck, the patient yells, patient shouts, and that is sometimes too gruesome for the third year BDA students who are watching us doing surgeries, and they'll come back to us, sir, ye kya ho raha hai, isko dard kyun ho raha hai, aapne aisa kya kar diya? So can you please enlighten on that aspect, sir?
See, to be very honest, what you said is absolutely correct. This used to happen in the government colleges when you get a case of cellulitis like this. But then, the best option would be to do a track and then kind of get the anesthesia, because you cannot intubate the patient in such cases because you fear of damaging those, the abscess locules and all, and that would go into the throat, right? That would go into the airway.
Aspiration.
Yeah, there is aspiration. Second thing is, because of the laryngeal edema, it will be difficult for them to pass the tube also. So the best thing is that if you really want to give good, the only way out is track. Otherwise, we have no other option but to do what you have said, and that is absolutely the way to go. I won't disagree with you. The only thing is, if you want to really avoid what is happening, the pain which is there, then we have to take these steps, and then you need to have good anesthetist.
I would like to add here. You can use midazolam.
Yeah.
You can use midazolam because patient will still be yelling, but he will not remember that he was yelling after some time because that amnesia is there with midazolam. So you can safely use midazolam, and patient will not curse you after the surgery.
Yeah.
But during the surgery with Midas, patient can tell us some good words, sir. Patient can speak up some nice
No, that is there.
during Midas.
Yeah.
Hallucinating and cursing the doctor who's supposed to. I've had this experience.
After that, he won't remember that.
He won't remember. He won't remember actually. Yeah.
Yes. Sir, one question also, sir. Sir, please carry on, sir.
Yeah. Otherwise, diazepam used to be much superior than midazolam. You used to get much better compliance. But amnesia is excellent in case of midazolam. So as a doctor, we would, and it is safer. So it is better to use midazolam and local anesthesia there. And
Shenoi, sir, one more question, sir. This is also from my side, sir. Sir, how often you emphasize your students or your residents to ensure that the patient gargles with a mouthwash, Hexidine or a betadine before anesthesia, sir? And what is the importance of that, sir?
See, I'll be very honest with you. Since post-COVID, we follow that particular routine. Otherwise, a very good practice, would be if you take a cotton applicator, dip it in betadine, a povidone iodine, and then paint the area where you're going to inject, as well as the tooth you're going to extract. That will be something even better. So, done the best infection control precaution that you need to do. So that is something that's very good. In addition, betadine, the use of betadine as a hemostatic is also there. So you can,
So thank you, sir. Dr. Deborah also had few questions. Dr. Deborah, can you come in, please?
Yes, I'm here. Am I audible?
Yeah, you are.
So there are a few favorite Viva questions that examiners have for students. And it will be really helpful if an expert like you can answer those same questions so that students are better informed.
Yeah.
So
thank God I'm not an examinee in front of you. So let's see.
It'll really be helpful for students because these questions we generally ask, and I think we end up giving incomplete answers to our students also. So we would really like to hear from you about one is patchy anesthesia. This is what we ask our students. So if you can tell us something.
I think I kind of covered it in my presentation, where that is when you
core fibers, mantle fibers.
Yes, core fibers and mantle fibers. That happens, and the basic, where people are worried, especially the dental practitioners would be worried, is that when you're doing in a case of irreversible pulpitis, okay, in those cases where anesthesia is very difficult to attain. If you're working with a good center or your own center, we've got good facilities. You can go for the X-tip system where you inject intraosseously. I spoke about it at the end of my lecture. With a preparatory injection, you just drill a small hole with the sleeve. It's a very minute sleeve, and the injection needle goes below it. You're just below the apices of the teeth, and you can secure anesthesia that way. Otherwise, if your local anesthesia fails despite the right techniques which you use, maybe you could blame the patient. Like the patient that I was talking about, because that patient had a bifid mandibular foramen, right? Basic reason would be, if everything given, I mean, these are all, once in a lifetime thing that happens. Not every day you get a bifid mandibular foramen. So
Yes,
in such cases, please ensure that you are using the right anatomical landmarks. You deposit the solution. And I think just before I rejoined, Professor Sanjay was talking about how you need to be supraperiosteal rather than subperiosteal. Right?
Yes.
You don't drag the needle over the bone. You hit the bone and withdraw it, and then ensure that you quoted a reasonable length of the nerve to be anesthetized.
Yes, sir. Yes, sir. Thank you, sir. I think that clears a lot of practical points on how we manage if we land up in such a case. The other question, sir, that students are asked is, what's the antidote to LA? Now, how significant is the use of an antidote? Do we really need it, and is it effective?
I would use it if I had it for pediatric patients. That is for sure. I don't know. I did a lot of research myself, but unfortunately, I don't know whether you get phentolamine mesylate. You get phentolamine mesylate, but that is used as
no, sir, we don't get it in India.
Yeah. So that is basically used for as an antihypertensive agent. You don't get it in the form of a cartridge for reversal of local anesthesia. So that is otherwise, if you are sure that your procedure is not going to last for a long time, why don't you use a local anesthesia without epinephrine?
A shorter duration to avoid this. Yes, sir. So one last question, sir. Does effectiveness of LA, I mean, is it in any way dependent on pain threshold of patients? Is it in any way related? We see so many patients who, even after a single dose, sometimes a double dose, not reacting. Is it somehow related to pain threshold, or are we looking at other factors?
It could be a combination. Most of what I spoke was based on my own experiences. I have this VIP lady, and unfortunately, lidocaine does not work on her. Articaine does not work on her. So this lady, I had to subject her to general anesthesia for removal of a grade 1 mobile first molar. So and the thing is that she's pretty heavily built. It's not very easy thing to do because when you're like me, getting the landmarks properly is a big problem. Yeah. So these are another Viva question which will be for the students is that apart from the degree of difficulty, like we talk about the impacted third molar, there are some factors which are beyond the tooth or the bone, and that is the build of the patient. So if you want to work around me, you need to have long arms because I am bulky myself, right? So you need to work around a lot around me to get into that particular target area. So these are things that are very important. Psychological factors also, there are some patients who would refuse to get a tooth extracted under or any procedure done under local anesthesia. I don't know. They have this, and more so, the affluent people have got a lot of problems. Earlier, since I did from GDC Nagpur, like I said right in the beginning of my lecture, if local didn't work, go for vocal.
Yes,
so,
sir.
that is what the literal sense. We had vocal for local much before what the government is saying right now. But then that was not the way to go about it.
So it's a privilege in government colleges where we can still do vocal for local. We can still do it, but it's private. It doesn't work.
There was this orthopedic colleague, sir. Orthopedic colleague. Who added one more phrase.
Sometimes
vocal. He was
vocal.
Thocal.
If not vocal, then thocal.
If not vocal, then thocal. So
I'm seeing
not ethical actually.
I saw a couple of questions in the chat box. Can we use IV ketamine for local anesthesia cases? Please don't do it yourself. Ketamine is not to be used by dentists. It has to be done with the help of a trained anesthetist, right? So please make sure that you have somebody to do it. Yes, you can do it. We've done certain cases in pediatric patients, but then the anesthetist was there. The reversal is very fast with ketamine. The ketamine is a habit-forming drug. So it's not very freely available. It's a highly restricted drug which is there. And one question that I can see is, what precautions do we take in post-COVID infiltration? Make sure that the patient is, not on any blood thinners. The patient has recovered adequately from COVID before you try to do any such thing. Because I'm in the COVID task force here in Nagpur district, in our discussions, it came to fore that, mucor has been reported in patients 100 days past COVID. So please make sure that you take adequate history of the patient. Otherwise, I don't see any problems. The patient, usually post-COVID patients could have diabetes as a part of it and blood thinners. So you need to be sure about that particular thing. So thank you so much.
Sir, there's one another question in the chat box, sir. It is from our endo colleague, Dr. Babita.
Okay.
And she's asking that it's a very informative lecture, sir. Thank you. Please give your opinion regarding how to differentiate between failed and wrong local anesthesia block from actual hot tooth, actually while doing RCTs.
Hot tooth,
generally, students get confused.
Yeah, hot tooth
Sir.
is, what my wife is an endodontist. And as a matter of fact, she is hosting a series of webinars this month called E-Link Fest 2021. I'm not a speaker over there. So
You should be.
we discussed about this at length. And I'm sure Dr. Babita would agree that in patients with irreversible pulpitis or something, it's very difficult to get anesthesia. So what you need to do is, apart from the routine blocks that you give, maybe intrapulpal anesthesia would help, if I'm not wrong. Or if you got X-tip with you or Stabident, please go ahead.
All right, sir. Thank you, sir. I think that answered all the queries of the attendees as well as the students. Dr. Deborah, can I just request you? Yeah, please.
There's just one question. Special considerations for a pregnant patient. I think that's just come in.
Special considerations for a pregnant patient. Usually, we would like to work when the patient is in the second trimester of pregnancy. Having said that, I have removed a third molar in a about to deliver patient. Maybe she was about 7 or 8 days to her due date. So the thing is that, you have to make the patient comfortable, right? Do not inject too much of local anesthesia, because though lidocaine may not, enter the fetal circulation, but you can't take a chance. The second thing is, do not work in such a way that you induce labor in the dental chair or wherever you're working. So you need to be careful about that. If the patient goes into syncope, make the patient turn the patient on the left lateral position rather than the position I talked about, the supine position. The left lateral position will relieve the weight of the gravid uterus from the inferior vena cava. Okay. Why not the right? Because that will push the liver also. So you need to turn the patient on the left lateral position, and the vena cava is slightly on the right side. So it's not exactly running in the midline. In the midline, it's slightly on the right side. So you want to prevent that. You want to have venous circulation going back. So that's why you turn the patient on the left lateral position.
Thank you so much, sir. Thank you so much. It was an enlightening experience interacting with you. I think the students also had the same thing.